Good afternoon. I think we have already discussed about the randomized control trial, how to proceed that one. But simply I will touch how we can design a good or ideal randomized control trial. So as per definition, what is randomized control trial? The synonym is randomized clinical trial. It's an epidemiological experiment in which subjects in a population are randomly allocated into groups, usually called study group and the control groups, to receive and not to receive an experimental, preventive, or therapeutic procedure, maneuver, or intervention. So that means we are categorizing our population into the study population into two types. One is the study group, second one is the control group. To one group we are giving the treatment, the other group we are not giving the treatment, and we are just looking for the outcome. So this is the basic design of a randomized control trial. This is the study populations. They have been randomizedly assigned into the one of the treatment and the other group to the new treatment, and then we are looking for the outcome, whether they are improving or not improving. Then we are evaluating by statistical analysis as well. So what is the level of evidence when we say RCT or randomized control trial? If you see, we can generate cause to effect relationship better with a randomized control trial, and hence it is at the peak of this pyramid. And obviously meta-analysis which are based on randomized control trial or good evidence RCTs are the topmost at the top of the pyramid. But obviously among the experimental group, if I would say, it is the top from the, that means from the cohort study, case control study, or the case series. So it's the gold standard of the study design. And what is the, why it is gold standard? Because it makes the group comparable, because we are taking care of the confounding variables. Suppose we are trying to look for the effect of tranexamic acid in TK. So we will make both the group comparable in the terms of age, sex, BMI, and everything. And we'll just look for one parameters, one variable that will left, that is the tranexamic effect on TK. So we'll look for the bleeding or hemoglobin drop in those patients. So that's why these groups are comparable, and it prevents selection bias. I would say in all study, there are different types of bias, but mainly we consider three types of bias. One is selection bias. Suppose I am studying tranexamic acid in TK and one fatty lady came. So what I would think that let me give it to the control group, because there is high chances of bleeding in such conditions. So that's the selection bias. To avoid that, I will do randomization so that I don't know exactly to which group this patient will belong to. The second problem occurs is the observation bias. That means the patient who is evaluating the outcome, suppose he knows that this patient is in the tranexamic acid group. So he will, obviously there will be a tendency to, that means categorize them under low bleeding or better, that means outcome group. So to avoid that, we do blinding, because if the observer or the evaluator doesn't know which group this study belongs to, that means this patient belongs to, then obviously there will be no bias. So we say selection bias and observation bias. So selection bias can be solved by randomization, and observer bias can be solved by blinding. So randomization and blinding, these are like brother and sister. So it's a true experiment, because if properly done, it can be used to determine cause and effect. And these are the basic steps how we should design an RCT. First, we have to make a protocol. We have to look, that means prepare the protocol, or like we prepare the thesis protocol, it's exactly the same thing. Second, selecting the reference group and the experimental populations. Then we randomize them, we intervene them, follow up, and then at last the assessment. It is exactly the PICO format: population, intervention, comparator group, and the outcome. So how we take the reference population, then experimental population. Suppose I am evaluating tranexamic acid and TK. So what is the reference population? It's the osteoarthritis patients who are going to be benefited after this trial. So they are the reference population. Then that means from that I will take the experimental populations, those who include the criteria. Basically after inclusion and exclusion criteria, I will take the study population from that group and then allocate them into two different interventions, either study group or the control group. Some patient will definitely be lost to follow up, and at last I will evaluate the outcome. So in the protocol I have to mention what is the rationale behind that study, why I am conducting that RCT, what is my aims and objectives, what is the research question or hypothesis, like the null hypothesis that we put in any research, we have to mention the research question. Then we have to describe the design of the study, how you are going to select the study and the control group. That means the inclusion and exclusion criteria you have to mention. Then you have to take ethical permission, then patient consent, and you have to explain the patient about the adverse event as well. Then document it, and then go for the procedure. So in the protocol, you have to mention everything about this. You have to put your research hypothesis, mention in detail about the inclusion, exclusion criteria, ethics, document it, and mention about your procedure. So reference for population or target population, population to which the findings of the trial, if found successful, are expected to be applicable. And experimental or study population, the actual population that participates in the experimental study. So osteoarthritis knee patients are the reference or target population. Whereas the study populations are after inclusion, exclusion criteria, some patient will be only entered into the study. Those are the study populations. So before taking them, you must give or obtain the informed consent from the patients. It should be representative of the population. They should be qualified or eligible for the trial. And before any study, we have to calculate the sample size. It has already been discussed by Dr. Ashok Shyam, so I'm not going to discuss this. And after that, we will do randomizations. So this is the heart of the control trial. To prevent confounding variables and that means a selection bias, we normally do randomizations. And there are different methods of randomizations. We'll discuss it later on. One is simple randomization. Then second one, the stratified randomization, block randomizations are there. But the most appropriate one is the computer generated list. So by randomization means we are making both the groups alike with regards to certain variables that might affect the outcomes of the experiment. So we are making both the groups similar, so that our finding or whatever the only variable that remain can have a cause and effect relationship. So then we have to mention about the manipulation or intervention that we are going to do in those patients. So either there may be deliberate applications or withdrawal or reduction of a suspected causal factor. So it creates an independent variables. So what are the types of intervention? Either it can be pharmaceuticals, like we can apply some drug. It may be a device. It may be a new procedure, or there may be some behavioral modifications. So follow-up, it implies that means certain regular interval of time, suppose 3 weeks, 6 weeks, 6 months, 1 year, we have to follow those patients. And one problem will occur that certain patients definitely will not come for follow-up. This is called attrition bias. And in the calculation of sample size, you have to take this attrition into account so that you have a proper sample size. And even after this attrition of those people, you are still having a good number of patients to have a positive, that means a statistically significant outcome. An assessment, either it can be primary outcome or a secondary outcome. You have to categorize your outcome into those two types. And the outcome may be either positive or negative. So I have already discussed this observer bias. To minimize that, either we can do a double-blinded or single-blinded study. Single-blinded means the patient doesn't know what treatment he is or she is receiving. Double means neither patient nor the investigator knows. And triple means neither the patient, investigator, or the analysts know about the intervention. So why randomized intervention is so important? Because it overall provides the strongest evidence. And these are the methods of randomizations. One is table of random numbers in the computer generated list. What is simple randomization? That if I will assign my patients, that means I will toss head and tail, and suppose I take head into one treatment group, tail into the other treatment group. That is a simple randomization, but it is not proper. It is called a pseudo randomization or quasi randomizations, because I may have unequal study and treatment group. If suppose out of 100, 70 times I get the head, so study group will be 70 and 30 will be the other group, control group. So that's the problem. According to date of birth, the number of hospital records, then alternative into the different study groups. So we want to assign a group of subjects into one or two groups that I have already discussed. So that's why we prefer random assignment. This is almost random or pseudo randomizations. I have already mentioned that. So the problem of this is the unequal sample size in both the groups. So if the study has very small sample size, there is no guarantee that two groups will have equal sample size using simple randomizations. So that's why we prefer either block randomizations. So suppose my sample size came out to be 24. So I will divide them into different blocks, and each block will contain 4. And there will be equal distribution of the two treatments in those blocks. So this is the example that I have already mentioned here. So after that, the potential problem I have already discussed, that if the sample size is very small in his simple randomization, there is no guarantee that the group will be comparable, and the solution is to stratify them. Then stratification means I will take certain factors. Stratification means I will take age and sex and then divide them accordingly. So this is the male patient between 25 to 44 years I have taken in one group, and the other female 45 to 64 years. And these two groups I have assigned 2 treatments. So now coming to different types of RCT, one is concurrent parallel designs and second one is the crossover design. Concurrent parallel study design means we'll follow these patients over a period of time. We'll assign them either into one treatment, either the study group or the control group. That means one will receive the treatment, other one will not receive the treatment. But it is a prospective cohort. That means we will cover them up to certain times. But what is crossover design? And this is that means the first one, the concurrent parallel study design. They have the control group, treatment group, and then at last follow up, and then we are comparing. But crossover means each group will receive both the treatment. So suppose A group, first they became the study group, then they became the second time the control group after completion of their first group. Then the group 2, initially they behave like a control group, and then they became the study group. So the problem here is that there will be carrying over effect. So the first treatment has ended and they have entered into the second treatment. So there may be some carrying over. So this is the concept statement I mentioned. For all RCTs, a randomized control trial, we have to publish it as per this criteria. So I'm not going to describe in detail. And all this format should be there. Everything should be there in that RCT. So these are the flow diagram of the process through which the phases of randomized trial goes. So types of RCTs we have already discussed. This is another form of trial. There is clinical trial or preventive trial. We can evaluate the risk factor, then certain cessation experience, trial of etiological agents, and we can evaluate different types of health services. And I think all these have been described. So thank you for your attention.